Now moving on to our third section, that is the spinal cord fracture management and its treatment. In this section, we will be discussing the principles of definite treatment. When once we have decided that it's unstable injury, we need to fix it, and how to deal with the patients with no neurological injury and those who have the neurological injury, and what are the different treatment methods, whether it's collar, hollow vest, hollow traction methods, spinal fusion, posterior instrumentation, anterior instrumentation. We will be briefly discussing over all the possible methods of definite fixation of the spinal cord injury. Now the principles. The objective of the treatment is to preserve the neurological function. If it's incomplete spinal cord injury, we have to prevent further neurological injury. To minimize the perceived threat of the neurological compression, to stabilize the spine, because it's important that incomplete injury can proceed to complete spinal cord injury if it's an unstable variety, and to rehabilitate the patient. What is important is the patient has suffered an injury, and once if patient comes out of the neurological injury, then we have to rehabilitate it so that it regains muscle function and muscle tone. Indication for urgent stabilizations are actually rare, but there have to be very specific indications which include an unstable fracture with incomplete neurological deficits. Why? Because if there's an incomplete and unstable fracture, if it is left as such, it would proceed to complete neurological injury due to unstable fracture. So that is an indication that even if there is not complete neurological injury, you have to fix it. Progressive neurological deficit with imaging confirming neural compression, that is mean this the unstable fracture and actually has progressing gradually at the vertebrae, actually slipping gradually, which may eventually lead to complete spinal cord injury if not fixed. In unstable fracture in a polytrauma patient, which is a relative indication. Now, when we are dealing with the polytrauma patients, we have other life-threatening injuries as well to deal with. But once we have dealt with the life-threatening injuries and we realize that it's an unstable fracture which is involving the middle and the posterior column, eventually, although at this moment the patient may have incomplete neurologic compromise, but eventually will develop complete neurologic compromise, or there's a risk of that, then we can fix it even if there is no associated neurologic compromise at this time. Now coming to the stability, what you call as fracture is stable or unstable. Clinical instability is defined as the loss in the ability of the spine under physiological loads to maintain relationships between the vertebrae in such a way that there is neither damage nor subsequent irritation to the spinal cord and nerve roots. What actually means is if the spine cannot maintain its normal alignment, so that it can function under normal circumstances, therefore this means this fracture pattern is unstable and it needs to be fixed, because otherwise either it will cause radiculopathy, myelopathy, or eventually it will cause complete neurological injury. So we have to prevent that before the unstable injuries lead to this kind of a disaster. So factors which are assessed in deciding on a clinical stability is actually the morphology of injury, that as I just told you, whether it's involving only the anterior column or it's involving the middle and posterior column as well. What type of injury it is a type A injury, which involves a burst fracture, a compression injury of the anterior column only, or is it type B or C injury, in which there is actually a rotational element as well as translational element as well, or there is associated type B is called as flexion distraction mechanism of injury is involved or not. Then integrity of posterior ligamentous complex. If posterior ligamentous complex is not intact, it's probably an unstable injury, and this will eventually lead to instability. Presence of neurological deficit, whether it is present or not, and these all three factors actually assess make up whether the injury is unstable and needs to be fixed, or injury is stable and can be managed conservatively. If we find out the injury was actually stable, then patients with no neurological injury should be dealt with stable injuries, and they usually need to be treated with bed rest until the pain and muscle subsides. Usually these involve the anterior column fractures, and they're usually without any neurological compromise, and they can be easily treated with rest, analgesics, and for pain control bracing may be used, but usually even the bracing is not really done often. Unstable injuries, if it's unstable injuries, usually they unite over 3 months, but that is unstable injuries without any neurological compromise. They involve part bud rest, part traction, and part bracing. Now, if there is an unstable injury and there is no neurological compromise, you cannot just leave it as such, because there is always a chance of that unstable injury eventually causing neurological compromise. So yes, they involve bed rest, but they can also involve some amount of some form of attraction and bracing as well. For example, you can use cervical collar, you can use hollow vest, or hollow traction can be applied as well, so that the in unstable injury does not causes the neurological compromise. Surgical stabilization standard for unstable spinal cord injuries: if there is a tendency or there is a chance it is progressing to cause a neurological compromise, then it becomes an absolute indication for surgical stabilization. Now, if there is a patient with neurological injury, that is either stable or unstable injury with neurological compromise, first and foremost is that we have to check the patient is out of spinal shock or not. Once this patient is out of spinal shock, we have to full extent of neurological injury is assessed. All the muscle charting is done, the reflexes charting is done, sensory and motor charting on the both the sides are actually done and actually documented on the Asia score. And then you may need an ICU or high care units requiring in case of acute injury. Once the patient is out of the spinal cord injury, then it can be actually shifted to either the feasible patients can be shifted to those areas where there's a spinal cord centers as soon as possible. But if for the further treatment, whether form of stabilization or any form of fixation. If it is stable spinal cord injury with neurological compromise, that can be treated conservatively and rehabilitated as soon as possible. Most common injuries include penetrating injuries from stab, bullets, and projectiles. And then because they are stable injuries, you do not need to fix them, but we need to just give them care for the neurological compromise they have suffered. Usually treatment method involves cervical spine, which could be form of soft collars, hard collars, and even semi-rigid collars. Usually soft collars are not really helpful, especially in case of complete spinal cord injury, but they can all be beneficial in form of restricted minor sprains, maybe in the first few days of injury when there is actually cervical muscle spasm. Semi-rigid collars are widely used in acute settings, and even hard collars can also be used as well, but are not actually adequate for unstable injury patterns. For unstable injury patterns, you have 4 posterior poster braces, which is more stable, and actually it involves a hollow vest, in which there is actually applying the pressure over the mandible and anteriorly. On the posteriorly, it's on the occiput, and when on the chest, it's applying pressure on the sternum and over the upper thoracic spine. So it's actually stabilizing the cervical spine by immobilizing the thoracic cage as well as the upper part of the basal-occiput region, so that the cervical spine load is shifted from the occiput directly to the thoracic spine. The use of tongs can be done as well, in which cervical traction can be placed. Pins can be put over here, just 1 centimeter above the pinna in the superficial mastoid region. And once this can be used to apply traction to the injuries, because if we are suspecting there is unstable injury which may not be associated with which may and may not be associated with spinal cord injury, we may need to apply traction to prevent further aggravation of the injury and leading to complete neurological compromise. So traction is actually applied to reduce the fracture or dislocation and to maintain the reduced position. Hollow ring, as I told you, on the anteriorly it's fixed to the mandible, posteriorly it is fixed to the occiput as well as the upper thoracic spine, and anteriorly it can be fixed on the sternum as well. Now this is actually useful, especially in the case of cervical cord injuries, and especially in the children. At least 4 pins need to be inserted on the outer tip of the skull, and ring is actually applied. Titanium pins and graphite actually ring allows the use of MRI scan to be performed, because once for 6 to 8 weeks have actually passed, and this kind of once after 6 to 8 weeks have passed, actually what results in, then we may need to get an MRI to see what is the status of the ligamentous injuries, soft tissue injuries. if there would be steel pins, then there would be definitely a problem with MRI. So we can use titanium pins and graphite actually rods, which can help to get an MRI in a patient even with this vest on. And it can be used for initial traction, reduction of fracture or dislocation, especially in the case of cervical fractures. Now coming to the fixation. Fixation, if you see, again coming back to that column theory, there is either you can fix the spine anteriorly or you can fix the spine posteriorly. Nowadays, there is actually a tendency to fix everything posteriorly, and approaches have been actually developed to fix more and more from posteriorly because it's very easy to approach spine posteriorly. But if there is actually problem with the anterior column only or a middle column, then you cannot sometimes go from behind, then you have to go anteriorly as well. So operative procedures depend upon the level and the pattern of injury. If you see this x-ray, it is actually a posterior fixation. Anteriorly the columns are actually, there is no anterior. Posterior fixation and stabilization is being done. Odontoid fractures at present can be actually have a different views. We will be discussing later on. The special type of views may be required to actually assess the odontoid fractures, which is called an open mouth view. And if they are present, then again further whether it's stable or unstable. If it looks unstable and need fixation, they can be simply fixed with a lag screw. Burst fracture are decompressed to the anterior approach because they're involving the anterior approach, and then we can use of graft, and cages can also be used to stabilize the anterior column fractures. Facial dislocations which are actually present in the posterior column, they can be easily reduced and fixed by use of posterior column posterior approaches. So spine can be stabilized either anteriorly with a plate or a cage, or posteriorly with interspinous wiring or use of pedicle screws and lateral mass screws, because lateral masses and pedicles present in the posterior column, and these can all be done. So the basic method is when we are dealing with anterior column, we have to go anteriorly, and when we are dealing with posterior column, we can go with the posterior approaches. So when it comes to thoracolumbar spine, for example, if we have to go into the anteriorly into the thoracolumbar spine, now there are so many things which are actually, we cannot just directly go in, because there is thoracic cavity, there is abdominal cavity which is actually lying anteriorly. So what's important is we have to have a way out of this as well. Now there are different beds which are actually available, and they're designed to actually decrease and avoid pressure sores. Special mattresses are the facility to turn the patient frequently. Bracings usually avoids flexion by 3-point fixation, which is only indicated if there is an unstable spinal cord injury and does not need fixation, but it may be suitable for some burst fracture, seat belt injuries, compressed fracture, but usually it's not necessary in the case of stable injuries. Now coming to the decompression stabilization. If there is a canal compromise, the fracture is such that it's a burst fracture involving the anterior, middle, and posterior column and actually compromising on the canal. So what we need to do is first we need to decompress the canal. We need to make sure that all the osseous elements are out of the vertebral canal, and then we need to stabilize it so that these osseous elements, the fracture fragments, do not come back into the canal. So the surgery is to reduce the fracture, then hold reduction and decompress the neural elements. It could be either anterior or posterior. If that's involving thoracolumbar spine and we have an anteriorly burst fracture which is actually causing the canal compromise, so then if we are going anteriorly, then we have to go transthoracic. There is no way we can directly approach spine anteriorly in this way. Or if it is involved thoracolumbar spine, we can go transdiaphragmatic as well or transperitoneal as well. Now transperitoneally, we can either go through the anteriorly like a laparotomy fashion, or we can use as anterior lateral approach to go retroperitoneally and then approach the spine anteriorly. For anterior fractures, especially if they're involving the neurological compromise, when we have to go for anterior approach, and this actually needs, sometimes we may, after even the posterior approach, there's no enough stabilization, so we need to augment our fixation anteriorly as well. So decompression stabilization can be done from posteriorly as well. And why it is required? Because if it is causing the canal compromise, there is loss of more than 50% of the vertebral height. More than 50% of the canal is compromised, and you need to decompress and stabilize the vertebral canal. Whether you fix it anteriorly or posteriorly, depending upon the geometry of injury, whether it's involving anterior column only, middle column only, or it's involving all the three columns. So posterior approach is for the most fractures, but if, for example, it's involving areas such as thoracic and lumbar region, then you probably have to go for interior approach as well. And some fractures are reduced indirectly by distraction with instrumentation and pedicle screw system. Now, this pedicle screw system is actually all the way through the posterior approaches. The pedicles are the holes are drilled in the pedicles, and the screws are placed, and then these rods can be placed over these pedicle screws, and then they can be distracted. This distraction of the vertebral fragments actually causes the reduction of the dislocation of the fracture pattern, and this distraction may lead to decompression of the vertebral canal as well. In this section, we have briefly gone through the different methods of the surgical stabilization of the cervical spine. What's important is to actually clinically assess the patient whether the fracture pattern is stable or unstable, whether the associated neurological compromise or not, and whether the patient, if the fracture pattern is stable and there is no neurological compromise, then probably bed rest, painkillers would be more than enough, and rehabilitation can be started. If there is unstable fracture but no neurological compromise, then we have to be on the very lookout for any advancing spinal cord injury. If there is progressive spinal cord compromise, then we have to go for surgical stabilization of that fracture. Usually this, if it's involving middle and posterior column, mostly it's unstable and it should be fixed. Now, if we are coming to fixation of the spinal cord, this could be a direct fixation or indirect fixation. Direct fixation could be that if there is no canal compromise, that can simply the vertebrae can be fixed. But if this canal compromise, then first we can apply the different methods such as transpedicle lateral screws, cause the distraction of these vertebrae, and indirectly decompress the spinal cord and then fix these vertebrae. So there are different methods. Approaches are also different. There could be anterior approach or there could be posterior approach. Posteriorly it's easy to approach, but anteriorly sometimes we have to apply as well. Anteriorly plates and cages can also be placed with grafting and without grafting, and all cages can be placed there as well. What's important is if we are dealing with thoracic spine going anteriorly, we have to go through the transthoracic, transdiaphragmatic approach. If we are dealing with lumbar spine and we have to go fix anteriorly, then we have to go maybe transperitoneal or transretroperitoneal approach as well. Thank you very much. Keep watching sqadia.com.